Okay, I think we'll go ahead and get started here and people can just join as we continue on with our presentation. But thank you for joining today. My name is Carrington Lott. I'm the program manager at Systems for Action. And if you're not familiar with Systems for Action, we are a signature research program of the Robert Wood Johnson Foundation. And our focus is funding research all across the United States that is looking at innovative ways of aligning the public health, social services, and medical sectors. So we have research that covers all different types of topics and sectors. And today you're going to be hearing from one of our research teams at Johns Hopkins University, and they're going to be talking about their research that was funded during our COVID Supplemental Funding Award back in 2020. And they'll be talking about how they're identifying COVID's best performers. So identifying factors and actions that enabled public health systems to bend the case curve faster than expected in the first phase of the pandemic. So let's go on to the next slide here. So I'll introduce our presenters and then I'll hand the reins over to them so they can tell you about their research. And then after they're finished with their research presentation, we'll be hearing from Ruth Mariana, who is the executive director at the Maryland Association of County Health Officers. So today you'll be hearing from Beth Resnick, who is a senior scientist at Johns Hopkins Bloomberg School of Public Health, the Department of Health Policy and Management. And we'll also be hearing from Allison Gimmel, who's a demographer and epidemiologist, and an associate professor at Johns Hopkins University. And we don't have a bio slide here for Vina, but Vina will also be presenting during this presentation. So she can give a brief introduction of herself when it's time for her to present. And then, like I said, we'll hear commentary from Ruth Mariana after their presentation. And then after commentary, we'll reserve some time for questions and answers. So if any questions come up at any point during today's webinar, make sure you use the Q&A box at the bottom of your Zoom screen and enter your question in, and we will make sure that we address that at the end of today's session. And then the final thing I'll say before handing it over to the research team is that today's presentation is recorded, and we will email the recording and the PowerPoint slides out to you after today's webinar. So with that, I think Allison is presenting first, so I will stop sharing my screen and let you share, and you can take over.
Okay, great. Thanks, Beth. So hi, everybody. Thank you for being here today. We're really excited to present this work. So first, let's talk about the system alignment problem that motivated our study. So our research question is, what were the core factors in public health system alignments that allowed for some counties to respond more effectively than others to COVID-19 in the first phase of the pandemic? And we're going to be using this first phase of the pandemic terminology, and really we're thinking about what's going on in 2020. And we had some key study considerations that we had in mind when we set up the study. And we were specifically really interested in what's going on at baseline. So again, this first phase of the pandemic, because we weren't as interested in what happened after counties received temporary surge funding. And instead, we were interested in baseline because we think that this reflects sustained public health capacity. In addition, we're interested in this initial phase because we think that effective initial response requires pre-existing awareness of and engagement with at-risk populations and capacities to address needs. So next slide. Okay, so our study is a mixed method study. So in the first part, we have our quantitative analysis. And in this part, we're really interested in identifying what we term positive deviants, or the best performing counties who bent their case curves the fastest. And we're using this terminology of bending case curves as a proxy for COVID control and COVID performance. And then we outreach to those health departments that we identified as best performers. We'll be talking a little bit about that. As you can imagine, it was quite challenging to recruit counties during COVID, and we can talk about those challenges a little bit later. And then we have our qualitative analysis component. So we did secure 14 interviews. That's what we're going to be talking about today, those study findings. And yeah, next slide. So first, I just want to go over the quantitative methods about how we identified these best performing counties. We have over 3,000 counties in the US. So how do we make sense of what's going on during COVID? And our main goal was to identify counties that did better than expected compared to other counties with similar characteristics. And this ensures that we have an apples to apples comparison instead of an apples to oranges comparison. Obviously, there's a lot of variation in the US, so we wanted to make sure we're capturing that. We used a total of 28 characteristics that were measured consistently for all counties, and we used those in our model. So these included things like population size, demographics. I'll give a few more examples in the next few slides. And then the way that we captured performance, there's different ways that you can say, well, did a county do really good at COVID control? And so the way that we measured it was by the time elapsed in days between a county's 10th case and the day of peak incidence of a county's local epidemic. And I'll show you those curves in a second. And again, we restricted our analysis to the time elapsed between the start of the pandemic and February 2021. So largely we're capturing what's going on in 2020. So next slide. So this was a pretty detailed exercise, as you can imagine. So we have on the left a county that did bend their case curves, and I'll describe this a bit. So in the blue line, we have the smooth number of cases. So this is showing daily incidence rates. And then in the red line, we have the smooth numbers of deaths. And you can see on the county on the left that they did bend the curve, right? This is what we were aiming for when we're talking about COVID control in 2020. And then on the right, we see a county that did not bend either their case curves or their death curves. And again, so for our quantitative analysis, we're really interested in the time elapsed between when the 10th case occurred in the county and the highest bent curve of 2020, peak incidence. Okay, next slide. So the data that we use are from the New York Times daily COVID-19 case database. This provided that daily granular data that allowed us to calculate those curves that you saw. And then we use survival analysis with time to bending the curve as a dependent variable in our model. And we controlled for a range of demographic, socioeconomic, population health, and health system level characteristics. And again, this ensures that we're doing that apples to apples comparison. Some of the other variables that we included were related to the percent of the population that voted for Trump, for example, because we think that we wanted to capture the political nature that might be influencing COVID dynamics in a county. And then we also measured temperature as another variable. So it's a really robust model, we think. And then after we did that, we calculated in step 4, the deviance residuals. And this allows us to identify counties that reach their case peaks sooner than we would have expected in the model. And we did stratify our analyses by density of population per square mile. Next slide. So after our models were run, we identified around 20 best performing counties in each National Center for Health Statistics urban-rural grouping. And you can see the 6 groupings below. So number 5 and 6, micropolitan and non-core, those are going to be the rural counties, and everything else is an urban county. Interestingly, we didn't identify any counties that belong to the large central metro designation, so those are not included in our study. Next slide. Okay, Veena. So Veena has been a great research assistant on this project, and she's going to talk about this component of reach outs because she led this part of the project. So thanks, Veena.
That's very kind. Thanks, Allison. Hi, everybody. I'm Veena. I'm a recently graduated undergrad, just graduated in May with a public health and social policy degree. Like Allison said, I've been a research assistant on this project, and I'll be talking about our interview process and reach out process and some of the struggles that we face in getting this done. So after identifying our top counties that performed exceptionally well according to their deviance scores, we then researched the public-facing county sentiments of each county. And this included looking at articles, public websites, social media, trying to identify some clear indication of specific governmental public health actions that were taking place by the officials in that county. And after confirming this, we reached out to the counties through multiple methods, first with an email, and then with 3 phone calls, because we know how things get lost in email. And of the 78 counties that we reached out to, only about 14 those counties got back to us and we were able to successfully interview them. So that's about 18% of the counties. We faced a lot of struggles here in terms of, first of all, getting someone to pick up the phone, and then also a number of individuals declined to interview with us for various reasons, whether they were busy or the adversarial relationship or harassment fears. And last but not least, for our interviews when we conducted them, each one was about 30 to 45 minutes with 8 questions each to probe out key factors of their response and what they thought was effective and ineffective. And then we did some double coding on those transcripts to identify key themes and features. In terms of, this table kind of breaks down of the rural and urban counties, how many fit the NCHS classification, but the key takeaway from here is that of our 14 interviews, 4 of them were for rural counties and 10 of them were from urban counties.
All right, thanks, Vina. Vina was also instrumental in putting together a flyer that we sent out to counties in hopes that this would make our project seem like it was based on true empirical evidence, that this wasn't a fake, a scam. We had some concerns about that. Another thing I wanted to say is that we did have the email, or the email was sent out by a collaborator of our project, Dr. David Bashai, who at the time was the health officer for Harford County. So it was coming from another county. So this is little snippets of the flyer that we created for each of the top or best performers. And you can see this county is blanked out here. But you can see for this county, it took them 297 days to bend the case curve, and they ranked 16th in large fringe metros. Next slide. The county also got to see the actual graph that we based our analysis on. So we hoped again that this would provide some solid empirical evidence for why this county was selected. I think some counties were surprised, but again, we tried to make it clear that really we were comparing apples to apples. Given their characteristics, they really outperformed what we would have expected. Okay, now on to findings.
Great, thanks Allison and Vina for that great information. So I'm Beth Resnick. I'm just going to share a little bit about what we found from the interviews, and I do want to highlight something that Allison and Vina mentioned a little bit. Most of the counties were surprised because I don't think anyone really felt like they had done a good job responding to COVID. And the one thing that was really cool was that they were kind of really excited once they heard that. And the fact sheets that Allison just described, many of them use that to show the elected officials or the other people in their own county. So that was really nice, like that there was a value to this. And I think all of us can think about, when we think about all the things that went wrong, oops, I don't know why this slideshow keeps jumping on its own. That all the things that we think about that went wrong in COVID, the idea to actually highlight some positives is kind of a cool thing. And it was actually really a nice opportunity to highlight some good work. In fact, one of the groups that I interviewed was talking about maybe getting t-shirts that said positive deviance. They were all excited about being recognized, and a way to share with their staff too, with all the hard work, which I know Ruth is going to talk about. But this is not easy times for health departments for sure. And look forward to hearing Ruth's comments on that. So first of all, what we found from the positive higher performers than expected was fairly uniformly across. And again, we're still finalizing our coding, but I think Vina coded all of them. All of them were coded by 2 people. But so we can talk about this more in the discussion if people will have questions. But some really big key things was this pre-existing partnerships. My husband works in the fire department. He had a fire chief that used to talk about the dog sniffing, the butt sniffing of you think about dogs out there in the dog park. You want that to happen before, right? You don't want to have a strange dog that you never met before, right? So having these existing partnerships, and again, they were across, what is going on with these slides? They were, going on across sectors. So not just one good partnership, but across things, different types of businesses and communities, nursing homes, healthcare providers. So having those relationships in advance, having some prior emergency response experience. No one wants to have bad things happen, but we definitely noticed a pattern where many of the ones had a flood or had some kind of disaster or some kind of thing where, again, they had to do that connections with people in advance. And this really helped them get along with the that quick relationship. I talked with one that like they had already been to their nursing homes before they even had a case in any nursing home. So building these protocols. So what were some of the challenges? And again, the higher performers had challenges too, like we all did. And I think Ruth will probably highlight these better than I can, but the challenges on the workforce and overworked, and even when those prior emergencies tended to be more short-term, these kept on going. You couldn't give people a day off. There wasn't anyone. Oh my goodness. I don't know why these slides. Oh, I guess it's on a timer. So I'm talking too much. But anyway, and then the federal, state, local. And again, I think Ruth is going to talk a lot about this in terms of communication and coordination. And obviously different states face different challenges based on whether the governor was aligned with what was happening at the local levels, the state health department, all of these different challenges. And again, those varied by state to state and even within localities, depending on people's different attitudes and things. And in some cases, the state actions bolstered what they were trying to do at the local level. And other times, maybe it didn't. It was a detriment. So again, Ruth is going to comment on all of these. And the last thing I wanted to just share was, so here were our findings that we just talked about. But what's the bottom line here? What are the implications? We need upgrades, right, to maintain these core capacities. We can't just get this surge funding, which again was why our project really focused in on sort of the baseline, because lots of people got a lot of extra money in 21 or even 22. But where do we start? That's the key thing, right? That you can rev up and get these things done quickly and get in front of it. Managerial capacity for staffing surge if needed. Of course, you can't have a full contact tracing team on board all the time if you're not in the middle of an emergency, but yet how can you bring those up and get those rolling fast? Can you shift people? And again, thinking about funding inflexibilities, how can you do that if you need to? Can you shift staff from one thing to another, but oh wait, they're funded on a grant that's only for smoking cessation, so the ability to have those kinds of flexibility. Whoa. And then again, these core capacity in EPI, communications, and partnerships, again, nothing that I don't think any of these things are surprising anyone. I think we all know this, but how do we then play it out and implement it and allow processes and funding mechanisms and things to allow for that? So I just pulled very briefly, and some of you might be familiar with this, but there's been two big projects that I'm familiar with nationally to sort of look at how can we learn from what happened and how can we build going forward. And there's now going to be infrastructure money available that I'm sure many of you know through the CDC grants. HRSA has some funding for workforce development. So I just pulled some national recommendations from some of these reports. These two are the Public Health Forward and the Commonwealth Fund Commission that have come out recently to say that it really is aligning with what we found with these different recommendations for sustained funding. Again, you can't just pile on money when the crisis hits. So we have this capacity. Coordination across the different levels of government is a big deal. So in terms of being able to have some kind of coordinating roles and procedures. And again, this core capabilities. So again, these are funded on an ongoing basis, not just in the moment. So I am going to stop there. Hopefully our slides will stop moving and turn it to Ruth, and who is the Executive Director of the Maryland Association of County Health Officers. I just wanted to highlight Ruth's office is in our School of Public Health, which is fantastic and really helps us build this relationship. The Maryland health officers all have faculty appointments at our school. In fact, Ruth and I have just been working on that this week. And so having her comment, I think, is going to be super helpful. So go ahead, Ruth, take it away.
Thank you, Beth. Appreciate the opportunity to talk with you today about our feedback about the project so far. So I'm, as has been said, I'm the Executive Director for the Maryland Association of County Health Officers, and it was the first and one of only two what we call a NACCHO, State Association of City and County Health Officers, that's located in a school of public health in the country. I think it's Indiana. That's the only other one, and that was pretty recently. So it's a unique place to be able to have partnerships like this and access to academic support for the local public health departments. So in Maryland, we have 24 local health departments. We have 24 jurisdictions, and each jurisdiction has a health department. And each health department has what we call a local health officer that leads that unit. And so our association is those 24 health officers, and they work together to coordinate local public health response. We're a pretty unified group, and we tend to do things as 24 members as one. So what's good for one is good for all. And that's kind of the approach that we took during the pandemic. So I agree with all of the findings for the strengths and the challenges. I wanted to speak about a few things that we saw, particularly in Maryland. So I think it's really key for the success of the COVID response and mitigation strategies was responding quickly and decisively with messaging and decision-making early on when there is a gap or a delay in messaging in a community or at a state level or even at the national level. We certainly saw that with the CDC, that there's perceived gap or weakness that a leader may come in that is not as familiar with public health response, and that can be detrimental. And I think we saw that where there was quick response and people were able in the community to gain trust in their public health leadership and their public health departments, in their state health departments. And where that did not rise, or people were waiting for the White House or the CDC or whoever to make a statement, it was easy for others to come in and fill it with disinformation or misinformation. And that was definitely detrimental. So I think local health departments are definitely uniquely positioned in their communities because they do have existing ties to multiple kinds of sectors. They are already participating in meetings. They can easily pick that up and then start to coordinate activities, which they certainly did during the pandemic. They have ties to nursing homes, assisted living, and other facilities, their correctional facilities, to already pick those communications up. As just a matter of picking up the phone and starting those plans. In Maryland, we have an incident command structure that we have had since 9/11. We practiced that, we planned for it, we exercised for it, and we instituted that right away, both at the state level and at the local level. What got complicated was there was some new leadership at the state level who was not familiar with that, and then they started to deviate from that ICS structure, which caused problems down the line for communication pathways, for response pathways, and communication pathways. The other part with stress and burnout, that the local health departments do not have the depth. They may have the expertise that's needed, and they definitely have the skill and experience, but they don't have the depth in the bench. So for a sustained emergency like the COVID pandemic has been, we just don't have enough people for that sustained 2.5 years into this emergency to keep going. And it's expensive to recruit. And it's also very challenging, and that's happening all over the country. What the state did at the state health department, they hired a bunch of very expensive contractors who lacked the skills. And so they were working alongside of state employees who were making much less money and doing the same job. So something that we tried to do was to get extra funding or pay for overtime for staff that were working the pandemic, that were working in local health departments. And a lot of that was denied. The problem that we ran into was that the systems that were at the state level for personnel and other types of things were really inflexible and unwilling or unable to adapt to work in a specific period of time to make it so that the people that work so hard to protect their communities could also feel good about that and feel like they were adequately paid. So that's something that I see for the future, that we really should work on these systems that can be adaptable and can be flexible in an emergency, and then go back to the system that they usually use in a non-emergency. Moving on to the recommendations. So I think that's really where we would like to focus on. The sustainable funding really should be less siloed coming from the federal level, so that health departments can be flexible and be more responsive to an emergency. It needs to be cross-cutting across programs, and people need to be talking to each other. I think there's work at the national level by one of our affiliate agencies, the National Association of City and County Health Officers, that is meeting with the CDC and explaining to them about what it's actually like to be a local health department and get this money. And then what are the barriers, what are the challenges, what are the opportunities to make that beneficial for a community. And I think they're making some improvements, which we saw in the recent workforce funding allocation. So I think that's very helpful. One point about communication, I think that there's a lot of opportunities to improve. Something that the CDC does as a science-based organization is wait to get the information and then push it out. And that delay, it caused so many problems. Locally, we need information right away. We need decisions right away. And we were hampered significantly by the state lack of willing to do that, or waiting for the governor to decide. In our case, he led the effort, and it was less about public health and more about what those decisions he wanted to make. And then also waiting for the CDC to come out. It really hurt the trust and confidence that a community has had in the local health departments. And that also hampered mitigation efforts and willingness to be compliant and follow. So opportunities for future research considerations. I think we should be looking at where do the threats exist for in public health, and it's not just communicable or infectious disease. It's also about public health authorities. Where are the gaps? What opposition do we perceive for the future? How can we prepare for those? How can we shore up our local public health and our national public health systems? I think we should also be looking at expanded collaboration across multi-sector entities. I just read about a project at Seattle King County Health Department, and they did a social determinants of health study that looked at how the mitigation efforts were actually impacted different communities. Was it equal? Was it fair? Was it just? And how can that be improved? Because obviously when you're trying, the things that protect you in an emergency and protect you are also things that can hurt your economy and hurt families and hurt individuals and businesses. So how can we move past that? How can we gather the data? There's a lot of data that could be available, but it's just not collected or not collected in the right way. So if we could position our other sectors to have data collection methods, we might be able to better manage the social determinants of health and actually know what our mitigation strategies do and how they impact a community, and was that effective. Data collection, it was very obvious in the pandemic that a lot of local health departments still use pen and paper and fax machines and all those kinds of things. We don't have the hardware and software and platforms and data that talk to each other. And that was a big barrier. We need to do something about that and really seriously invest in those systems. And then we also need standardization of data collection across the different states too, so that we're all reporting the same thing. And we're now faced with a situation where we know that cases are rising, but we don't know the true story about that because not everybody is reporting any longer. So that's challenging. And finally, talking about research and practice, I think we should be looking at the public health authorities that exist, where there are gaps. Like in Maryland, we have no protection for our health officers from threats and harassment. They exist for local elected officials and state officials, but not for health officers, and that we're not the only one state in the country that doesn't have it. We should be looking at those kinds of things. We should be shoring up our data, sharing data abilities, our data use agreements. We should not be so hard to share the data that we need to do the work. So how can we make those changes at the national, state, and local levels? And then we should also be looking at what does it take to make a decision as a local health official, state health official? What is the decision-making intelligence? What goes into making that decision? How do you get the right information? What goes into that process to increase the outcomes? How do you involve multidisciplinary teams to do that? How do you involve the community so it's not just one entity that's making the decision? And then I think finally we need to look at rural and small local health departments and making sure that they have what they need to do in an emergency. Thank you for the opportunity to provide the feedback.
Thank you so much to the research team for giving us an update on their research project and for sharing some of their findings that they found this far. And Ruth, thank you so much for providing commentary. I feel like we could have an entire presentation just on the topics that you covered. So let me share my screen again. We're here at the Q&A portion of our webinar. So if you have any questions, please feel free to enter them into the Q&A box and we can make sure that we address them. So I'm going to go through these in order. I see one came in from Lava. They ask, how did you ascertain what time to use and when the bending of the curve occurred? How did you rule out the transient bending, not real bending?
This is a great question because, as you know, there were multiple waves that occurred in 2020. So when we first started the project, we ended our timeline around July 2020, and we were measuring peaks, and it was much easier then because there, over the summer we saw case counts go down, and then of course we had a different pattern in the fall. So this was actually a really involved part of the project, and it's something that we worked on back in 2020. And we hired a team of research assistants to actually vouch for what our algorithm was saying was a real bend or not. So they actually visually inspected all 3,000 counties. And so that ensured, in addition to the decision rules that we had in the algorithm, this additional level of visual inspection ensured that we were capturing a true bend. So hopefully that answers your question.
I would just wanted to add one thing. I think that was also where Vina did the research on if there was activities, public health protections in place, or appeared to be. So again, so that it wasn't just a random, or they just didn't have any COVID in that small local area, that it was actually actions that had made a difference.
Great, thank you both for responding to that. So our next question comes from Mark. How does your outcome, time to bending the curve, correlate with other outcomes with face value, like total case counts by population and total deaths, et cetera?
Yeah, this is a good question. So we did find face value. So things like population density seemed to matter. The demographics mattered. So the percent that had, in counties that had younger populations, we saw quicker time to bending the curve. Also, more testing meant quicker times to bending the curve. I think I have to go back to the paper, but this is a good question. So we actually have a paper, and I'm gonna I have it ready to put in the chat. So we have a quantitative paper that looked at factors that were related to successful control in the first few months, so up to July. And we were specifically focused on past local government health spending and also spending at the state level. And we didn't find that that county level spending really affected whether there was successful COVID control or not. But we did find that state level spending on hazard preparation seemed to matter. So if you're interested, you could look at that paper that I put in the chat. And so what we've done is we extended that model through February 2021 to identify the positive deviance, which I know you have other questions about, and they're great questions. Do you want me to take the next one, Carrington?
Yeah, sure.
Okay, so next one was how many counties analyzed, how much variability is there across counties in your outcome, how much variability after adjustment for the 28 county characteristics, and how different were the positive deviants than the others before and after adjustment. So these are really great questions, and I actually don't think I can answer them all right now. So there was a lot of variability, and I didn't say this, but by February 2021, about 75% of counties had bent their curve up to that point, but we know we were starting to see additional surges due to Alpha and then later Delta. But this is kind of prior to the Alpha variant. So at that point, 75% of counties had bent their curves. All counties were included. We did exclude some that had unusual data, but it was very small. And all counties were included in the survival analysis because even if they did not bend the curve, they were still in the risk set. So for those of you who know survival analysis, that hopefully makes sense. And I think your questions are good about comparing, about looking at the variability after adjustment and comparing before and after the adjustment. So I'm going to flag those, and that's something we can definitely do going forward. Okay, so I'm flagging that. And then your next question, I appreciate the positive deviance approach, but how confident are you that the interview responses themes are actually associated with your outcomes? In other words, would negative deviance have given you the same responses themes? So this is a really great question. And Beth, you can help me out here too. But when we first started this project, we were like, do we want to look at the negative deviance too? And we thought that was probably not the route we wanted to go. But, you know, we're obviously only interviewing 14 counties here, given the constraints with being able to recruit counties. But I'm going to speak for myself here. I was actually surprised that we were seeing some common themes emerge, especially around having prior experience with emergency response. So yeah, I mean, the study definitely suffers from some limitations related to our response rate, but I was surprised pleasantly. I don't know, Beth, do you have other?
Yeah, I just wanted to add a couple things because initially we did want to look at the negative counties and see if there was some themes there, and we still could go back and look maybe structurally at those. It is a good point. And doing the research that Vina did around, was there any actions taken or what was in the press at the time around it? But two things. One, we didn't want to contact a county and be like, hey, you did worse than expected. Like, we didn't think that would necessarily be a very good outreach. And then the second thing, and again, this is probably more anecdotal, so it might be helpful to look at it. But in the most part, I would assume that if it's a negative, they did worse than expected, we wouldn't really be able to find much. There probably wouldn't either, like maybe there was a shift in personnel. So we could, that is a good point. We could look at that a little bit more. And then I think the point that Allison said, when we started out with the positive deviance and we started to see some themes going, and I think Ruth could probably reiterate this from her own experiences, that, you know, when there was already existing relationships and leadership in place that had been there and knew people, that tended to make a difference in terms of what happened. I don't know, Ruth, if you want to comment at all.
I'm sorry, I was putting some information in the chat for Jean. So I found an article that helped with that. So Beth, could you restate what you?
Yeah, I was just saying the question, Mark asked a good question in the Q&A about, well, do you think you would have heard anything the same from the negative deviance? And I was saying that I think we saw, and Allison was pointing out, we saw some themes across the good ones, even though there was only 14 that did better than expected. But I think the concept of having this existing relationships and building and having those in place beforehand, I think does make a difference. That has been found in other situations as well.
Oh, most definitely, because you can pick up and just start right away and you don't have to build those relationships. We saw that with the state health department because they didn't have those existing relationships in the community, and they had to come to us for access to that, or sometimes they didn't and they had difficulty with it. And we were able to help bridge some of that with them. If you have to create things from scratch, it just makes things so much more complicated.
Thanks, Ruth.
Thank you all for responding to that. And then Ruth, I know you're working on there's a question that came into the chat. I'm going to go ahead and read it out loud because I don't think anybody else can see that question because it just comes to the panelists. So Jean's question was, I would like to know how human service sector collaborations like cash benefit and other human services direct service delivery capacity were represented in collaborations that you observed. So I don't know if the research team and Ruth want to address it, but I'll just hand it over to whoever wants to comment first.
I was going to say a quick word because I think this is a great question and something I'm really passionate and interested in as well. I think when it came to our interviews, not many folks talked about like cash benefit and pre-existing social services, but almost everyone talked about community partnerships when it came to accessing food, supporting older adults at home, especially those who were secluded and couldn't access, senior centers and usual services that they could. And that was almost always across the board. And I think it just goes to show what Ruth was talking about before, that community partnerships are really important for good public health work, and incorporating that also strengthens the structure when we're responding to emergencies too.
I would add that the problem with that is that there just isn't the data collection methods and tools to do that. Either the data isn't collected in the way that we needed it to be, so then there's a gap, you have to then go back and figure that out, or the systems aren't able to talk to each other, you can't collect it. And then something else that Seattle King County noticed, that the people that they talked to in the community said that the data that you're showing doesn't include my community. I don't see myself in that data. And then so then it must not apply to me, or that's a deficiency, it's an inequity. So I think there's still just huge gaps in the data collection, data reporting, data systems, and equity issues around data collection.
All right, thank you. And then Ruth, I know you and Allison and Vina have all shared some things in the chat, and I'll make sure that I include those in our follow-up communications to everyone who is registered for today's webinar so that they have those resources later. So we have one more question in the Q&A. We have, let's see, a question from Shelley. Was there time to compare the COVID response to other national communicable disease responses like Ebola?
I don't think it came up in our interviews at all. But I'm trying to think, were there any other examples of communicable diseases that were that participants? Yeah.
Just one, Allison. Just one county talked about Ebola, and that was going back to having previous emergency management experience. Mm-hmm.
But I think, in all honesty, that COVID really is unique in the sense that it was happening everywhere at the same time. So oftentimes when there might have been something in the past, number one, it was a much smaller scale. I mean, much, lesser time period, but also if you had an outbreak or say food poisoning or something, I know that's not communicable disease, but in a different way, you could have other people from other counties come help you. Whereas in this situation, everybody was under the same circumstances at the same time. You can't get anybody else to help you. And, it was so vast and so long and continuous. So I don't really think comparing to any of those other ones would have actually been an apples to apples. But it's a good thought,
a good point too about how this was happening everywhere all at once, and it's just kind of like an all hands on deck type situation. Did any counties that you spoke to talk about reaching out to other counties to see what they were doing to identify things that were working?
So I think Ruth could talk to this more. I mean, there was definitely constant calls and things across different states and counties and things and meetings. But again, I think everyone was sort of grasping in the moment. You know, I don't know if anyone was publishing anything yet or anything like that, but I know there was a lot of ongoing calls and things with some of the national organizations, letting people, you know, jump on and hearing what people were doing. But Ruth, I don't know if you want to comment more specifically.
That's where our association really comes in handy, because we had 24 health officers who came together daily at the very beginning, weekly after that, and we meet monthly on a regular basis. And then we talk all the time about, what are you doing? What are you doing? What are you doing? And we would coordinate sometimes with the leadership in our counties, our county executives. Some of them wanted, the big eight, wanted to kind of do things together because their statistics were kind of overflowing, and share hospital systems, share public health systems. And so that, yeah, that's tremendously useful, and always benchmarking about, if this is the trigger, then that. So constantly thinking about what's going to be happening, and what we should be doing together, and so that we could all stay on the same message, or use science-based decision making.
Great. Well, thank you. I don't see any other questions in the Q&A or in the chat. So I think what I'll do is just run through a couple of systems for action announcements, unless the research team has anything else they want to say before
I just wanted to add one thing. And, you know, obviously I know Hopkins because that's where we're at, but I do think also in terms of academic institutions and things and other centers, that was also another role that they played. Clearly, Hopkins had the map and lots of things going on in terms of sharing information as well. So again, I think for research community thinking about going forward, that is an area I think that could be super helpful. Although again, we have to be clear, we're all staying on, part of the problem was everyone might not been on the same message, but I do think that might be an area, Carrington, that there could be some more discussion on, because it definitely was tough in the moment for everybody trying to scramble to get whatever information they could.
Yeah, absolutely. Thank you. Okay, so with that, we do offer a certificate of completion for those of you who joined today. So if you're interested in that, there will be a really, really brief survey as soon as today's webinar is finished, and you can indicate whether you would like a certificate of completion or not, and we'll get that to you in a timely manner. And then today, we just released a notice of, or we just released a funding opportunity, like just this morning, and we're really excited about it. We're going to be offering two different types of awards. We'll have a development award and an impact award, and our development award is going to be focused on funding some pilot studies, so offering up to $100,000 for up to 12 months worth of a study to look at systems alignment. And then our impact studies will offer up to $500K for up to 3 years. And with those impact studies, you must have proof of pilot test results. And last year we had a really kind of specific focus on this wrong pocket problem, and those are the types of studies that we were funding. But this year we've gone a little bit more general, and we're looking at just, you know, systems alignment more broadly in terms of the public health, social services, and medical sector. So if you're interested in learning more, I've included 2 links here that I will include in the email follow-up communication. And this funding opportunity will be open until October 5th. So you have some time to work on your proposals. And then, of course, acknowledgement to Robert Wood Johnson that we are a National Research Program Office and we receive our funding from them. But I really appreciate everyone joining today to hear from our research team, and we will be hosting another webinar in 2 weeks. So we look forward to having you join us for some future research presentations. And with that, I hope everyone has a wonderful day.
Thank you so much, everybody.